Okay, good afternoon. I have the dubious honor of being the first postprandial talk. And as we all heard this morning, I am in for a great challenge to keep you engaged during a time when physiology dictates that your attention is dipping. So I will do my best to do that. I think I'm aided in this goal by having a topic that is very timely, extremely important, and really quite exciting for us as a field. And I'm going to talk about the latest generation of Alzheimer's disease prevention clinical trials. These are my disclosures. None of these have any impact or relationship to any of the things that I'm going to talk about. And I like to start with these two men. Just show of hands, how many people know who either of these two individuals are? So in the top left, we have James Watson, co-discoverer of the double helix, the structure of deoxyribonucleic acid, DNA. In the bottom right, we have Craig Venter, leader of the for-profit side of the race to sequence the human genome. The for-profit side narrowly defeated the not-for-profit side in that race. And these two individuals were the first two human beings to have their genome sequenced. So these are the first two human beings to ever have their genome sequenced. Dr. Watson chose to learn every gene available except one. He chose not to learn his status for the apolipoprotein E genotype. This is the most powerful and well-replicated genetic risk factor for sporadic Alzheimer's disease. He had an aunt who had Alzheimer's disease, and he said he had no desire to know if he was at increased risk to succumb to that demise. Craig Venter learned every gene, including that he was a carrier for the ApoE4 allele, and as such was at approximately 3 times increased risk for getting Alzheimer's disease himself. I think it's hard to imagine two individuals more informed than these two about a decision such as this one, whether to learn risk status for Alzheimer's disease, yet they came to exact opposite decisions. And it's this that's the backdrop for the component of my talk and the component of the latest generation of clinical trials in Alzheimer's disease that I'm going to focus on today. So my agenda is to talk about the scenarios in which it's acceptable to tell people their risk status for Alzheimer's disease. And our knowledge about who will and who will not get Alzheimer's disease continues to evolve at a rapid pace, making it critical for us to consider these things fully. I'll talk about the ethical concerns in doing trials that utilize this risk information, and throughout, I'll do my best to talk about the types of data that we can collect to instruct our field. So an increasing number of surveys and other research studies have been examining this very issue and to what extent people want this information. And here I provide a summary of several recent publications and studies in our literature. And by and large, these studies have been almost surprisingly consistent in showing that a majority of individuals, when asked, will say they want to know if they are someday going to get Alzheimer's disease or if they are at increased risk to someday get Alzheimer's disease. These numbers appear to even increase when we focus on the elderly, so people 65 and older. Now, most of these studies are hypothetical in nature, and they ask questions about predictive testing. If we had 100% predictive blood test, if we had 100% predictive genetic test, would you want this information? And of course, though we are learning at exceptional rates, we still don't have predictive tests for who will and who will not get Alzheimer's disease. But we have more and more tools in our toolbox to try to understand this. And I think hallmark among these tools is positron emission tomography with a specific ligand for beta amyloid or amyloid PET. The data here are from John Morris and Washington University. They're among the first prospective data for risk for dementia among cognitively normal people who demonstrate elevated levels of brain amyloid on these PET scans. And what this study showed was that compared to people who don't have elevated brain amyloid, cognitively normal people who do have elevated amyloid are at about 480 times the risk for progression to dementia. And studies like this one have led to the formation of diagnostic criteria for something we're now calling preclinical Alzheimer's disease. Demonstration of Alzheimer's disease biological markers in people who have normal memory. And we're going to talk about clinical trials being performed in this very population of people. Now, this amyloid PET has actually achieved FDA approval. 3 specific ligands have achieved FDA approval. And here I'm presenting appropriate use criteria from a group of radiologists, neurologists, psychiatrists, and bioethicists that were assembled to articulate a document as to in whom this PET technology should be used. And I highlight that they very specifically outline that cognitively normal people, the very people scanned in the study on the previous slide, were deemed inappropriate for this amyloid imaging. And combined with my earlier slide that people want to know, in a majority sense, want to know if they are at increased risk, this creates a disconnect between what patients and research participants want, to some extent what investigators want, because there are surveys of Alzheimer's researchers about whether they wish to share this information and think it would be meaningful to those enrolling in our studies, and between regulatory guidelines and ethical guidelines for research as to whether we can or should share this information. Now, I use this term preclinical AD. This is a published set of diagnostic criteria put forward by a group sponsored by the National Institute on Aging and the Alzheimer's Association. They are research criteria. Today I'm going to be talking about the use of these technologies and designs in research. I will not make any comments about clinical use of this technology. But in the research setting, there are now multiple clinical trials enrolling cognitively normal people who could be described as having preclinical AD, people who have genetic or biomarker evidence of being at increased risk for someday getting dementia caused by Alzheimer's disease, who are then randomly assigned to a drug or a placebo, or multiple drugs depending on the trial, or in some cases, a lifestyle intervention, to see if that intervention can delay the onset or prevent people from getting cognitive impairment and dementia. Now, these trials listed on this slide can be divided into groups in a number of ways. Some are being conducted in the extremely rare form of Alzheimer's disease that is autosomal dominant, purely genetic, affecting probably around 1% of all people who get Alzheimer's disease, versus the more common sporadic form of Alzheimer's disease. But they can also be divided in their implemented design as to whether or not they are telling people if they demonstrate the risk criteria that makes it possible for these studies to test interventions in as efficient a way as possible. So these 2 designs for prevention clinical trials have been termed blinded and transparent enrollment designs. In blinded enrollment designs, we enroll at least a portion of people who do not meet the criteria for preclinical AD, whatever they are for that particular trial. So a portion of people who don't carry the right genes, or a portion of people who don't have elevated brain amyloid. The purpose of enrolling some people who don't meet these criteria is that we then aren't telling people whether they meet the criteria when we tell them if they're eligible to be in the study. Alternatively, transparent enrollment designs enroll only people meeting biomarker or genetic criteria for preclinical AD, and then randomly assign them to drug or placebo. Transparent designs, by definition, are smaller. They require fewer participants. They take less time to answer a scientific question, and they're associated with reduced cost because the majority of cost in a clinical trial stems from how many people you're enrolling. I'm going to evaluate these trial designs using criteria for ethical research put forward by Zeke Emanuel, Christine Grady, and David Wendler in 2000. I'm not going to have time to go through all 7 criteria, so I'm going to try to focus on 3 in particular: informed consent, respect for individuals, and scientific validity. So first, informed consent. We're putting people into these trials, and the information that we give them in order for them to make a decision if this is something they want to do is obviously of critical nature. Both of these trial designs have unique risks, and some of the literature approaching this debate has actually missed some of the important risks associated with each design. In blinded designs, we typically, most trials that use blinded designs, will non-randomly assign people who fail to meet risk criteria to placebo. And then they will go through the entire trial in its full complement of the protocol, because anything less would be unblinding. So these people have MRIs, they come in and have all the cognitive tests, they have however many visits are required. If it's an infused therapy, they're coming in and they're getting saline infused into their arm once every 4 weeks in some cases. So they're at risk for suffering an adverse event related to those procedures without any real potential benefit on an individual level from the treatment, because they don't meet the criteria for the type of people we're trying to help with the drugs we're developing. I think more important and of greater risk is the fact that when we enroll people who don't want to know if they demonstrate these risk criteria into studies like this, we have to be aware that if they have an adverse event related to the therapy, if they have brain swelling or brain bleeding that shows up on an MRI because they're taking an amyloid-lowering therapy, not only will they have had an adverse event, a risk that they signed on for when they enrolled in the clinical trial, they also run the risk of then learning that because they got assigned to the group getting the active drug, they know that they meet criteria for preclinical AD being used by that trial. And this is a scenario where they could learn this information without the benefit of a disclosure process, counseling, and a decision to learn that information. And that, in my mind, is an extremely important risk that must be considered in blinded trials. On the flip side, in transparent enrollment designs, it's well described that there is a risk of psychological reaction to learning this information. People have to learn if they have elevated levels of brain amyloid. They have to be equipped and prepared to receive that information, and we yet don't know if people are equipped and able to learn this information. This is highly understudied. We also have extremely limited information to share with these people who are participating in trials. I mean, I cited a hazard ratio from one small study from one site, but we don't have proportionate numbers to share with people, and we certainly don't have any information for the prognosis of when dementia will begin, if it is going to begin. And later we'll talk about the disclosure process that we're undertaking to share this information, but the amount of information that we have at our disposal right now is extremely limited. Now, some investigators have suggested that requiring people to learn if they have an AD biomarker to be in trials is coercive. But the Belmont report defines coercion as an overt threat of harm in order to elicit compliance. And not enrolling in a trial is not in any way harmful. Trials are voluntary as a rule. Nor is the opportunity to have an amyloid PET scan or a genetic test and the access to experts to perform that and share that information with you an improper or inappropriate reward, what the Belmont report defines as undue influence. So I would argue that transparent designs are not unethical due to reasons of coercion or undue influence, but to be ethical, they must be feasible. To enroll people in a clinical trial that ultimately will not move the field forward is unethical. We put people at risk without the social benefit of knowledge gained. So we need to do trials that we're confident can complete enrollment and answer scientific questions. And the feasibility of these trials, especially for transparent enrollment designs, remains an open question. And we have been trying to answer this question by collecting data. So I'm going to tell you about two studies, one that was recently published and one that we're hoping I'll be able to say was recently published soon. First, I'm going to talk about a study from the Dominantly Inherited Alzheimer's Network. This is a longitudinal natural history study of the people at risk for this rare autosomal dominant form of Alzheimer's disease. We recently published survey data from this study. Now, the DIAN includes family members who had a parent with this extremely rare form of the disease. It's an early onset form of the disease. The age of onset is typically in the 3rd, 4th, or 5th decade of life. There are 3 genes that can be mutated. There are more than 250 mutations that have been identified and can be tested for. Now, the DIAN does not require people to learn their genetic status for the sake of participating in the study. Participants are given the option to undergo anonymous testing and genetic counseling, but it is not a requirement. And I apologize for the busyness of this slide, but we did a survey of people participating in this study to try to understand a little bit more about their attitudes toward genetic testing, clinical trial participation, specifically prevention trial participation, and the interaction between these two things. And what we found, I think, is quite interesting. First, 40% of respondents said that they already knew their genetic status. This is immensely higher than everything in the literature studying these families. Most of the papers available suggest that only about 10% undergo predictive testing and learn their status. We found that 40% did, and another 15% said that they hadn't undergone testing, but that they wanted to. They wanted to know. Among these people, there was an extremely high willingness to participate in clinical trials. Among the other 45% of participants in the study, those who said they did not wish to know their status, 70% said that they would be willing to learn their status if learning that they carried a mutation meant the opportunity to enroll in a clinical trial. This, too, sort of turns the literature on its ear. Now this, I would argue, warrants further study. The trial that was described to individuals completing the survey was of a promising therapy that we hoped would be able to delay the onset of Alzheimer's disease. And these people could be at risk for what we call the therapeutic misconception, a belief that if they learn their mutation status, they'd gain access to a drug that would prevent them from getting Alzheimer's disease. Alternatively, they may simply have adjusted their risk-benefit analysis of the decision whether to undergo testing when the risk is learning that you carry a mutation, and now the benefit has the added component of enrolling in research to try to help yourself and 50% of your relatives by assisting researchers in finding treatments for this disease. Now, in the sporadic form of the disease, the 98% of people who get Alzheimer's disease, we've also recently completed a study where we enrolled 132 people that we recruited from the community, cognitively normal people who are at least 65 years old. And we wanted to know, is this requirement of learning your biomarker status going to delay our ability to do these trials? Would trials that require people to learn their biomarker status have slower recruitment than trials that enroll everyone who's willing to participate? So we did an interview study to assess this, and I'll just briefly summarize that we found no difference in the rates at which people said they were willing to be in trials comparing blinded to transparent enrollment designs. And in fact, 70% of people in the transparent design that tells people their status said they were likely to participate compared to 61% in the blinded design. So I actually think learning this information about oneself could be an incentive to people for enrolling in these studies. And I think that that's in line with a lot of other studies that have been published over the last few years about people participating in research. They want to feel like they're part of something and that they're part of the team. They don't want to be treated like patients. They want to be treated like part of the research team, which is exactly how we do it here at UCI. Now, even though these two studies provide support for the notion of using transparent designs and the feasibility of using these designs in prevention clinical trials, it's not enough to make these trial designs ethical. We still have other obligations as researchers, especially to the people choosing to enroll, and that's getting to respect for participants. And respect for participants in transparent design trials begins with the manner in which we're sharing this information, again, be it genetic or biomarker in nature. And Jason Karlowicz at the University of Pennsylvania led an effort to develop a process for sharing this information for the first clinical trial in sporadic AD, first prevention clinical trial in sporadic AD, what's known as the anti-amyloid and asymptomatic Alzheimer's disease trial, or the A4 study. In A4, we're only enrolling and randomizing people who have elevated brain levels of amyloid shown on a PET scan. And we developed a process to tell people the results of their PET scan, that is, to tell them whether they have elevated amyloid or not. The manner by which this process is illustrated here was a modified Delphi process. Experts in informed consent, amyloid imaging, and clinical trials were reached out to and asked what they felt were the most important aspects that this process would need to deal with. There was an iterative process to evolve what was shared and the manner in which it was shared. This is also now published. The highlights from this process are that it is heavily dependent on participant education. We're educating participants not only about what we know about amyloid PET and risk, but also what we don't know. And in fact, we make them tell us back how little we know in this process. Enrollment in this study is not diagnostic. It is not predictive of who will and who will not get Alzheimer's disease. It is demonstrative of increased risk, enabling us to do the study, but we cannot offer individual level prognostic information. The process is very specifically articulated as needing to occur on multiple days. We don't consent someone and do the PET scan on the same day, and we don't tell someone the results of their PET scan on the same day of having done the scan. People are given an opportunity multiple times to change their mind, and before we share the information, and I often use the phrase, before the toothpaste is out of the tube, we give them the opportunity to say, you know what, I'm not sure I do want to know this. Maybe we should postpone. We're also extremely careful about measuring the ability of these people to handle this information that we're about to share with them. And that's done through a number of psychological outcomes, both during the pre-scan screen and after scanning. This includes measurements of depression, anxiety, suicidality, and other interesting aspects of an individual's desire to know their risk for getting Alzheimer's disease and their reasons for wanting this type of information, i.e. the results of their PET scan. Now, some interesting things have actually emerged since we began the A4 study. We've been doing the A4 study for over a year now. It's going well. The disclosure process seems to be working quite well, and I'm part of an internal ethics committee for the A4 study that reviews data from the items you see here on a regular basis, and the process seems to be working quite efficiently. One thing that's interesting is there was a recent paper from the Australian flagship Neuroimaging and Biomarkers Lifestyle Study, or ABLE, that suggested among people who have elevated brain amyloid, it's people with anxiety who demonstrate the greatest cognitive decline over time. And this is interesting from the standpoint of scientific validity because these people are actually likely to be excluded from A4. And this may potentially hinder our ability to show a drug effect on preventing cognitive decline if we have inadvertently removed the people most likely to decline. Now, this is one study, this needs replication, but these are the kinds of things that we must consider when thinking about the scientific validity of our prevention clinical trials. Another thing that I think is not only worth talking about, something we must talk about, is that there are increasing studies to suggest one reason that people want this information is so that they can use it as guiding in their plans of whether to commit suicide. These are data from Rick Caselli in Arizona, and he has published 2 studies now, one from a very large registry of people who don't have in-person clinic visits, in which they found 12% of people said that they wanted this information to be instructive for such planning, and perhaps a more rigorous study involving their ApoE cohort, people who come in for clinical visits and have genetic blood tests as part of the study, though they are not given the results. The rate went down to about 6% of people who said they wanted this information for this for these purposes. So even if we use the more conservative estimate from his 2 studies of 6%, we're talking about a meaningful proportion of people who could be participating in our studies, in part to use this information in this manner. And I think that this really necessitates a national, international dialogue among experts to think about how we're going to handle this and what the implications are to our trials. There are some voices in our field who are putting forward the message that this is a viable strategy for people who believe they're at increased risk for disease. And thoughtful investigators need to get ahead of this dialogue as soon as possible. And trialists need to consider the potential implications to our work and the implications of someone committing suicide before we finish our trial, for example. Now, the risk factors for suicide in Alzheimer's disease are fairly well described. Suicide among patients diagnosed with dementia is most common among males who are still mild in their disease, and they typically have a history of depression and access to firearms. In Dr. Caselli's paper, they tried to examine similar risk factors, and only one thing reached significance, and it was being unwed. So we are really dealing with a blank slate here, and we frankly don't know what we're up against. So this is something that truly needs further study. Risk to participants in these studies can and must go beyond assessing psychological outcomes in the research clinic. Jason Karlowicz and Jelaine Arias have a very nice paper overviewing the legal and the healthcare implications of being preclinical AD. Most of these trials are being done at major academic medical centers that have electronic medical records. If we're not careful, this information could go into an electronic medical record and insurers could have access to this. We have some laws, and we're trying to get better about protecting people for pre-existing conditions and genetic risk factor information, but even the Genetic Information Non-Discrimination Act fails to address biomarker evidence, and it fails to include things like long-term care insurance. So we must protect the people who are making it possible for us to take these critical next steps in trying to prevent Alzheimer's disease. As probably everyone in this room knows, Alzheimer's disease is also associated with an extremely unfortunate stigma of loss of personhood and loss of self. And we don't have any idea the extent to which people who are told they are eligible for a preclinical AD clinical trial will face similar stigmas, be it at home, in the workplace, because these people are very active still and often still employed, or even in the doctor's office if their physician becomes aware that they have elevated brain amyloid. There's also the potential for self-stigma. Some small focus group studies in people who have MCI, mild cognitive impairment, suggest that the challenges these patients face include a lack of certainty related to the prognosis or whether they have a disease versus a risk condition. And I suspect that studies will find this could be exacerbated in cognitively normal people who are enrolled in preclinical AD trials. Self-stigma could also affect our data. Now, these are data from Tara Lineweaver when she was at UCSD with the ADRC down there. She did a nested case control study. So this was not a randomized trial. This was taking people who were participating in other studies that either did or did not share genetic information with participants. And what she found was that people who were told that they carried the ApoE4 allele, making them at increased risk to someday get Alzheimer's disease, they demonstrated worse cognitive performance than people who weren't told they were E4 carriers, and certainly worse than people who were told they were non-carriers. So to the extent that our preclinical AD trials are based on studies, large natural history studies, that don't tell people anything about their prognosis, we may be building, for example, our power calculations to decide just how many people we need in a trial to be powered to show a drug effect. We may be basing those calculations on the wrong data. And this could hurt the scientific validity of our studies. So there are many things, and I am in no way saying we shouldn't be doing the trials we're doing and that we mustn't do the next ones. We can, we are, we must, but we have to do a lot of work to make sure we get better as we do this, and we have to use the first trials to instruct the next wave. Now, the dream scenario for us, of course, is that we're going to show that some of these drugs actually delay the onset of cognitive impairment and dementia. And there will be challenges that we face in that setting as well, and in the setting of these drugs achieving FDA approval. And we will need research and thoughtful consideration of these issues as well, because we're doing these trials because we need drugs that can delay the onset of cognitive impairment. Amyloid PET scans, the only biomarker with FDA approval now, is an expensive endeavor. It could be a costly venture to do this in a mass screening approach. So we will need to pursue alternatives, I'm sure, and we will need to tackle this as well. We have to think about who we're going to treat, and perhaps more importantly, who's not going to be treated. We need to help everyone at risk for Alzheimer's disease, and this is a disease that knows no ethical or social bounds. And many of the treatments that are under development will have substantial risks, and those risks could be even more extreme with chronic administration. And most of the trials are now being designed around 3-year outcomes. Thankfully, most of them have planned long-term extension studies to give us more information around the chronic use of these treatments. But people with an elevated brain amyloid PET scan may not develop cognitive impairment for 15 years. Our goal is to delay that. We could be talking about decades of therapy. So we're really going to have to figure out research to understand these issues and protect people who are receiving these treatments. And lastly, and an extremely challenging issue, when is it time to stop these disease-slowing therapies? People have approached this issue in dementia. When is it the case that you no longer want to slow the course of dementia? But again, we're going to turn this issue on its ear when we start talking about initiating therapies in cognitively normal older people. So in summary, I believe that requiring the disclosure of risk information in the setting of preclinical AD trials is not unethical, and that we can implement transparent designs in a responsible way. And indeed, I think ethically we must do these trials in as efficient a manner as possible. To be ethical, however, these trials must be feasible, and we need more data on the feasibility of implementing these challenging designs. We also need more data to understand how people approach the decision of whether to learn risk information, whether to participate in trials, and whether these two things interact in some way. And we really have to consider this perhaps even more so in the setting of purely genetic conditions where instead of risk, we're really talking about true genetic diagnosis. So with that, I'm going to stop and thank a variety of wonderful colleagues who made most of this talk and all of the work possible. Jason Karlowicz is a mentor and collaborator from the University of Pennsylvania and helped in essentially everything that I talked about. Yan Zhao and David Elshoff are colleagues from UCLA who helped with one of the studies I described. The Diane study team is listed here, led by Randy Bateman and John Morris at Washington University. It's a real pleasure for me to be a part of the internal ethics committee for the A4 study, and Jason, Jeff Burns, and David Saltzer make it really fun to be a part of that, and Risa Sperling is the PI of the study and very supportive of us. And I want to acknowledge the Alzheimer's Association and the National Institute on Aging, especially for the funding of some of the work that I described. And I thank you all for being here and for staying almost 100% awake in the first postprandial talk of the day, and I'm happy to take a question or two if there's time.
Looks like we have questions already. So.
I do want to know if I have a marker. My mother and her sister went the same way with Alzheimer's and schizophrenia, and my sister and I do want to know. How do we go about doing that?
Yeah, so right now, I would say the best way is to be in research and to be in a study that is carefully sharing this information with participants, and that is a limited number of studies. So A4 is certainly among them. There are other trials that are coming down the pike soon. You know, I have to say, unfortunately, one of the hardest things about doing clinical trials is that we tell most people who want to enroll that they're not eligible for one reason or another. In Alzheimer's disease, I've published a paper saying 70% of dementia patients are not eligible for trials. Lon Schneider from USC has a paper suggesting it's as high as 90%. So it's not always as simple as just signing up and getting the information. But right now, I think that is absolutely the safest way to learn this information. There have been other ways that have been available to people for things like genetic tests. There are imaging facilities, I'm sure, that will offer scans to people despite being specifically outlined as inappropriate for those scans. But I think people really need to do this in a thoughtful way, consulting with experts, if at all possible, and research is the best way to do that.
In a economical way, incarcerated people, would they be used in a study like this?
Incarcerated people are typically deemed ineligible for research unless the study is interested in something about their incarceration. And that is because of the risks for things like undue influence and coercion, which are magnified in that setting.
What typically makes people ineligible for a study?
Yeah, so the question is what makes people ineligible for a study, and it's going to vary substantially from study to study. In the A4 study, which is the study we're sort of very focused on at the moment, we are telling a lot of people they're not eligible because their memory isn't normal enough. And someone's memory can be too good or not quite good enough, but not meet our criteria for normal. I would argue many of those people are still normal. They're just not our normal. Among the people who have normal memories, 2 out of every 3 are going to be told they're not eligible because of the results of their PET scan. And that, combined with some other factors, is making A4 extremely challenging for us, and that's why we're working our tails off to get it filled, because we really want to answer this question. And the next wave of these trials is coming. And one question, and we tell everyone who participates in A4, we're not likely to cure the disease with this one study, but it is among the most important steps we'll have ever taken.
Back there, go ahead, and then this one up here, and then that'll be.
Okay, yeah. Yeah.
Okay, go ahead in the back. Okay, thank you. At the beginning of your talk, you were going over some things, and you mentioned something called lifestyle intervention. Can you elaborate on that?
Well, I mentioned one specific study from Australia. So I would say there are two studies in the world that are really setting a pace for understanding age-related and Alzheimer's-related brain changes through biomarkers, neuroimaging, PET imaging, and CSF studies. And one is here, the Alzheimer's Disease Neuroimaging Initiative, led by Mike Weiner at UCSF, or ADNI, and one is in Australia. I probably got the name slightly wrong, but it's something akin to the Australian flagship study of biomarkers and lifestyle interventions, but we call it ABLE, and that's why I never remember exactly, because it doesn't quite spell out. But it's led by Colin Masters and Chris Rowe in Melbourne, and one of the studies I had a slide from looking at anxiety and amyloid interaction for who shows cognitive decline was specifically from that study.
Okay,
Last question.
Thank you. I have a question for you. My kid sister and her husband went into a neurological clinic in Orange and were volunteering to be part of a study, and they were being tested. They'd been tested for about, 30, 40 minutes. And an intern came into the room where they were being tested and said, "Sorry, we can't use you, you're testing too high."
Yeah.
What could that be about?
Well, so as I said, for not knowing their case specifically, but for example, we do memory testing. And if someone's memory is too good, they are deemed ineligible for the study. And what I tell everyone, no matter what reason, high or low, is that the study has been designed with remarkable caution and rigor, and our job as scientists, first and foremost, is to answer a question. And so we've designed the study, and I say we, I mean Risa Sperling by and large, has designed the study to be extremely careful to not include people who could hinder our ability to answer a scientific question. And there is some concern that among people whose memories are extremely good, that maybe they won't decline no matter what. And so a decision was made when designing the trial that people whose memories were too good would not be enrolled in the study. Okay, thanks very much.